better? Okay, I'll just continue here if I just, okay. This is the radiographs of the first patient in Concord Hospital to have a total ankle arthroplasty implanted. He was a retired school teacher who had advanced arthritis of the ankle, and after extensive discussions on options, he chose a total ankle arthroplasty, and we introduced this technique here at Concord Hospital. He's doing very nicely. This is a STAR, Scandinavian Total Ankle Arthroplasty, which is a mobile bearing, third generation ankle replacement that has been FDA approved for use in this condition. And it was a fascinating experience with the support of the hospital. We were able to successfully perform this surgery, and we've obviously not doing surgeries of this nature during the pandemic, but before the pandemic we had gone on to the second total ankle arthroplasty as well. As part of this talk, I prepared some comparisons and as an overview of the talk today. I'm going to speak on ankle arthrodesis, the history of ankle arthroplasty, what's the difference between the historic fixed and the more modern mobile bearing, what are the indications, some comments on surgical technique, and what happens if and when these devices fail, and just a few thoughts on what lies ahead. Ankle arthritis or arthrosis, most commonly is after a trauma. Sprained ankles are very common. Ankle fractures, less common, but equally devastating. It's the same degree of disability for an ankle as one would consider for a bad hip in terms of severity of function, impact on daily activities. And historically, the option that surgeons would recommend for advanced symptomatic arthritis was a fusion or arthrodesis, where the arthritic segment is moving, it's painful, we limit the motion, and when the typical treatments such as bracing that externally limit motion fail or are not good enough to control the pain, then we would internally block and lock that motion with what's called a fusion procedure. And historically, that's remained the gold standard surgical treatment. This is an example of an ankle fusion. This also was done at Concord Hospital. This is an anterior ankle fusion plate and a side x-ray or sagittal x-ray, where the plate is just the device and it holds the position of the tibia to the talus bone, which compromise the ankle joint. This is a locking plate where the screws quite literally lock into the plate. It's a very strong titanium device and is one of the more modern ways of accomplishing this surgery. And historically, this has been the procedure of choice. There are numerous techniques for doing this. What's called a transfibular approach, an open anterior approach. This is the way this procedure is done. And commonly on an outpatient basis, an arthroscopic assisted ankle fusion. Those techniques have been around for a very long time. They're quite refined. And in a lot of circumstances are a very, very good way to go. Another example of an open technique, this was a transfibular technique where we literally cut the fibula bone and use part of the fibula as a plate and then multiple screw construct. This metallic implant was a piece of a broken screw that I did not remove because it wasn't causing any problems. This was an old ankle fracture where a lot of the metal had previously broken and some of it had been removed. It was inconsequential to have exposed him to risk to remove that broken implant. So that's not part of the construct, but another example of an ankle fusion. The problem with fusions are that historically, eventually, people become symptomatic of other joints. It limits the motion. This is an essential joint. And at least in one long-term study, 50% of people reported to be handicapped in ADLs, just normal activities. It was difficult when they didn't have a function of their ankle. Their pain from the arthritis may have been improved, but the function is really what was challenged here. This is another example of an ankle fusion. There's no retained metal in this ankle. The tibia and the talus are melded together. And the typical disability is around the adjacent joints, what are called Chopard and the ST or subtalar joints. So the joint below the ankle and the joint next to the ankle, which really take the function of the shock absorbing role of the ankle, those joints degrade and disintegrate over time because they're asked to do more than they normally would. If you have an ankle that's fused in position, every time you step, there's some degree of motion of that foot, and the joints that aren't fused, that still can move, are accepting a larger degree of strain and become symptomatic over time. Initially, they probably aren't, but over time, they certainly do. And it's thought that these are the areas that cause ongoing or persistent disability eventually after a fusion. And another challenge, this is a separate case with an anterior ankle fusion, and these are CT cuts where the bone has mended fully on the CT cuts months after an ankle fusion, and yet the patient still had significant pain, but no substantial arthritis in the adjacent joints. And this is also something that comes up. Where is the pain coming from? And we do see a painful ankle fusion even when the fusion itself is technically successful. The bone has mended, but the patient is dissatisfied. And this is a challenge. So the thought process historically is that there is room for improvement in the gold standard. Everyone has known that for years, and I would go so far as to say decades. The challenge is that it's the ankle. The technology wasn't available to do anything besides this procedure when external devices such as bracing proved ineffective. And the technical challenges are that the ankle is not a knee and it's not a hip. For a hip and a knee, these are very larger joints. There's a tremendous number of implants that are available to accommodate the wide variety of human size and shapes. And these joints technically are easy to access because you can dislocate them without causing damage. You can dislocate the hip during the procedure and evaluate the entire socket. You can dislocate the knee during the procedure, which is part of the procedure, and you can evaluate the entirety of the joint. You can't dislocate the ankle. The exposures are much larger and wider in the hip and the knee. The exposure in the ankle is much smaller, so the field of view is smaller. You can't dislocate the joint safely. And so it's a much different technical challenge. Soft tissue is thin, a few millimeters in some cases around the ankle versus inches of muscle around the hip. You can't dislocate. The interaction of the joint is much different. This is a small bone called the talus, sitting on a larger bone called the tibia that compromise the joint. It's a hinge, but it also rotates. And in certain points, just with standard walking, it's 5 to 7 times body weight that goes across that interface in a hinge and a rotation with every step, and it's a small location. So the mechanical stresses are very high, and then the distal part of the bone near the joint of the tibia is what we call spongiform, and if you remove more than a centimeter, you reduce its strength by over 50%. So the amount of bone that can be resected to accommodate an implant with even advanced arthritis is minimal. And then the last is the blood flow. The blood flow to the bone, particularly the talus, comes through multiple arteries, and depending on prior trauma, which is a significant proportion of folks who are suffering with advanced arthritis, many of whom have had prior surgery, the blood flow, if that's compromised, replacement can lead to bone death, what we call avascular necrosis. And when someone has had a prior surgery, by definition, their anatomy will be distorted. And so what is the status of the blood flow, particularly if we want an implant to interface with bone without causing further damage to the remaining bone? So, having said all that, implant. This was the Mark 7, and this is a polyethylene tibia. It's just a piece of plastic in orthogonal views, so if you can imagine the two different angles, that's why it looks like this. And then the talus component, so the top of the tibia bone and then the talus, and they were cemented in place. It's a fine concept, but understanding the complexities of the mechanics, it really didn't work very well, and it led to some pretty catastrophic failures. And there were some strict indications for doing the surgery, and just intuitively, without going through a period of trial and error, people were thoughtful about coming up with a list of folks who really would be disqualified from consideration of that type of implant. And those included folks who had neuromuscular dysfunction or disorders, where muscle balance would force a joint into an awkward position and add to the strain. Different types of neuropathic conditions, most commonly diabetics, what we call Charcot, a history of infection, that remains the standard for most of our implants in arthroplasty. And then severe osteopenia, or weak bone. The bone needs to support the implant. If the strength of the implant is orders of magnitude greater than the strength of the bone, with every step, the implant is going to subside or shift within that bone and sink. And that's intuitive in terms of who could benefit, who could not. These were pulled from the market because they failed horribly. And this was a radiograph that I borrowed of a Mark 7, and there's substantial bone destruction. If you remember that first slide, it looked a little goofy to see a piece of metal in an ankle, but if you remember, if you could intuitively think what an ankle might look like on an x-ray, it kind of looks like that, except it has the metal cast. Well, this is all grayed out. The bone has subsided. The talus bone should be here, going up, not sunk down several centimeters. This is a catastrophic failure and frequently led to amputation in these circumstances. Things changed in 1984. I put a picture of Frank Alvine. This gentleman is credited, this physician is credited with the resurgence and popularity of ankle replacements. He coordinated design of an implant called the Agility implant. That was the one I was trained to use. It's not available on the market anymore because of its long-term failure rate, but it was a very good implant for the time in terms of understanding how an ankle arthroplasty is performed and refining some of the techniques. And it was a second-generation implant. And it was put in extensively. There are lots of folks who still have an Agility arthroplasty walking around the community. This is a picture of the Agility. It's a second generation where the plastic is part of the tibia and the talus moves freely. It was modified numerous times during its evolution and was implanted extensively. One of the modifications was a platform onto the talus so it didn't subside. The third generation of implants were what are called mobile bearing or having multiple segments, where the polyethylene or plastic component was not part of the talus component. There are multiple examples of this newer generation. This product is called a Salto-Talaris implant. It was very popular in Europe, and if you're familiar with how the FDA approves implants, the European model was a, quote, mobile bearing model. So this piece of metal and this piece of plastic actually didn't connect and didn't lock in, but they were able to rotate freely on themselves. And that's the European design. There is, at the time, no FDA approval for a mobile bearing implant. And so the FDA has this interesting process called a 510K process where you don't actually have to prove efficacy, you have to prove similarity. And so the company that marketed this redesigned it completely, rebuilt it, called it the same name, not to be too disparaging, and made a fixed bearing device and got it approved, and so the fixed bearing device is used in the United States with some success. This is a very popular device, and like a lot of them have some failures associated. This is photographs that I had borrowed from colleagues on x-rays with a Salto. These are pictures where some of these other plates and screws are due to trauma. These are post-traumatic arthritis. On the left-handed x-ray, this is an old rod called a rush rod and a medial plate, a more standard fibula plate, and two screws for what was called a bimalleolar ankle fracture, and the Salto implanted. A gal that I know here in Concord has a Salto in. She went down to Boston to have that done. She's done strikingly well with it. I think that some of these implants have a role, but this one was approved through a 510K process. And the design concerns and design concepts have evolved, and that's really what's led to now starting these implants to be utilized in the Concord community now that we have a device that has a true FDA approval, which is the STAR implant, and it's a mobile bearing with a solid 10-year track record. This slide I included as part of the orthopedic presentation. There's a lot of pros and cons to why different design components are important, and what are the good and the bad of the different design components. The rotational stress, the force transfer. There's no ideal component, there's no ideal implant, and it's arguable which is an idealized, what part of the mechanics do we address, and what do we compromise to address that part of the mechanics. Again, pros and cons. For a mobile bearing, this is the implant that was approved for use by the FDA, and the implant that I've utilized here at Concord Hospital. I personally like the notion of the implant where it's a stress transfer through a mobile bearing, and the implant design is such that it is designed to grow into bone with minimal bone cuts. So we remove the minimum amount of bone, have a surface that can interface with the native bone, and then have the stress relieving component of polyethylene so that the stress is not directly transferred to the bone implant interface, it's transferred through the mobile bearing component. So the ideal component, high conformity, it fits the ankle, minimal constraint, it moves freely to minimize the junctional strain, and with minimal resection of bone. There's numerous types that are out there, multiple that are approved through the FDA, and there's a role for utilizing different implants in different circumstances, undoubtedly. And generally these implants are approved through a 510K process. If you get into the weeds of medical implants and devices, there's a lot of ways that things get approved. Again, this is a similarity approval process versus an efficacy approval process. So if you have an implant that's similar to an existing implant that's already approved, even if that implant were approved through a similarity process, it can get approved. And that's true for most things that are utilized in medicine these days. So what do we use arthroplasty, or what do we offer arthroplasty for? Post-traumatic arthritis, osteoarthritis, which is rare, rheumatoid arthritis, the inflammatory conditions. And then you can see by the slide the reasons why we might want to avoid an arthroplasty is pretty significant as well. And this is true today, this was true 10 years ago, that selection is important for survivability. The implant itself does not guarantee success. It has to be put in correctly, and it has to be put in a person who is a reasonable candidate to have that as an option for treatment. And then there are warnings for arthroplasty use as well. So who's the ideal candidate for an arthroplasty? Somebody who's relatively thin, they're active, not an athlete. I jokingly put that as part of the talk. We don't want someone to expect to be able to go running on an arthroplasty, although theoretically it could be possible. And then they have an isolated joint that's arthritic. They don't have substantial arthritis in the joints adjacent. And they have excellent motion. Somebody who has a very stiff ankle before replacement is going to have a very stiff ankle after replacement. Interestingly enough, motion isn't typically increased after arthroplasty. It is maintained. And no deformity. This is a key component, and they're relatively healthy so that they can handle a general anesthetic and the medical comorbidities associated with any type of surgery, including a major joint replacement. So how do we do it? Arthroplasty is multiple ways. The most common is through an anterior approach. It's directly in line with the front of the ankle. There are implants that go through the side of the ankle. I have no personal experience with those, but there's one arthroplasty that can be done through a lateral approach. The anterior approach, and you can look at your own ankle. Even in the heaviest of folks, there's not much skin there. It's skin, there's a little nerve, artery, a couple of tendons, we move it out of the way, and you're looking right at the bone. And that's why we're so cautious about wound complications, because there's really not much there that can handle a skin breakdown. Even a non-infectious skin breakdown can prove catastrophic. This was the technique for the old agility system. Again, this is not on the market anymore, but interestingly enough, a lot of the technique parameters are very similar. Now they're evolving, but they're similar. We distract the ankle, we apply jigs. A jig is a cutting block, so we can align the ankle in line with the leg, so we create some sort of template for the mechanical axis of the leg, so that we have something that's bearing at a 90-degree angle. In general, if you have something that's cattywampus, every step you take, it's going to load abnormally. But if intuitively it's at a right angle to the mechanical axis, then it should at least wear more evenly and distribute those forces. And the techniques for these are designed to create that correct weight-bearing axis alignment. We pin the jig or cutting blocks in position and sequentially change out the cutting blocks for the pins, and then create a surface where we can make our bone cuts. And this is an example by fluoroscopy. This is a sagittal saw or side cutting saw through a jig. Again, this is a jig on an older implant design, but it's the same concept. And then we measure and mark. There are devices that will place on the cut surfaces to correct for rotation, and then sequentially pin those in position, and then add sizing blocks, sizing jigs, and then ultimately place an implant. Again, this is an old agility where you want the implant to interface with the tibia and the talus appropriately for articulation. So the pitfalls, just intuitively, we don't want to create an implant that's too tight in the joint. That's a technical error. We want to make sure that any associated tendon contractures around the foot and ankle that have been acquired due to the underlying condition, typically post-traumatic arthritis, are appropriately addressed. Removing bone spurs that can later impinge, what are called gutter cleanouts, and ultimately repairing what we had to go through to get to the joint itself. If one thinks about the tendons in the front of the ankle, similarly in the hand, when I extend my fingers, the tendons lie against the bone through a series of ligaments, and they don't, quote, bowstring. To get to the front of the ankle, we have to remove, at least release that transverse ligament to get the tendons out of the way to access the joint. And if we don't repair that appropriately, when one extends their ankle, those tendons, instead of sitting nicely against the bone, will, quote, bowstring, and that becomes problematic. And ultimately, this is a mechanical device. Implants can shift, they can move. There are consequences of the motion. This is an agility. Most of my prior experience was with agility. Most of the pictures that I have are failures of the agility. This is a talus that shifted. This little extra line is called lysis. Typically, we'll obtain a CT scan, since plain radiographs are suggestive, but unfortunately they underestimate what's truly happening, and we'll see where typically caused because of that interface, and the bone quite literally erodes away, and that needs bone grafting and further adjustments of the implant. And ultimately, like any orthopedic device, it still requires the body to do its thing as well. The bone has to grow into the implant, and if it doesn't, it's called a non-union, and there's motion where motion really shouldn't exist. We want motion between the ankle, and with the mobile bearing devices, we would like motion between the implant and the polyethylene plastic. We wouldn't want motion between the bone and the implant. That would be a non-united segment and could lead to early failure of the implant, and certainly would lead to early pain. This was a x-ray of a gentleman who hoped for an ankle replacement. He still might ultimately be a candidate, but as you see, this was one of the x-rays I selected to express this. This deformity may in fact be more amenable to an ankle replacement because of the plane of deformity, but a significant deformity of the foot and ankle in this location just intuitively would be very difficult to restore a more normal mechanical access with a substantial deformity. So the importance of the technique is it can't be overstated, and if you have substantial deformity, the level of the ankle, that extends to the level of the ankle, you can't correct that with cuts through the tibia. You can't remove enough bone to change substantial mechanical abnormalities. And then there are abnormalities within the ankle itself, and this is what's called a valgus ankle, and that's what's called a varus ankle, where the ankle mechanical access and the leg mechanical access, well, you'll have to trust me because we did appropriate films, but the mechanical access is straight, but the ankle itself is falling off into a different direction. So the foot is drifting off of the mechanical access, and this one called valgus alignment into a more flat foot position, and on the right-hand slot into a higher arched or quote varus positioning despite a normal mechanical access. And balancing procedures despite normal restoration of mechanical access must be done as part of these implants. Otherwise, when the implant is put in, it's going to look fine, but the second people weight bear, they're going to have these laxities, and then the implant itself will fall off in either respective direction and lead to an early failure. And also avoiding further pitfalls. We try and avoid this if possible. This is what's called a pan-talar fusion, where the, this lower joint called the calcaneal cuboid joint, the majority of this bone is fused, it's in an awkward position, it's flexed, the tibia goes this way, this person is essentially in a high heel position. The treatment for this person ultimately is, she was a woman and we advised that she wear a wedge. And interestingly enough, she was able to get away without doing a surgery just because she changed all her shoes to wedges. The positioning is very important. This was a gal that came into the office, and again, she has bad arthritis of the ankle, but her mechanical access suggests a substantial bowing of the tibia. So the mechanical access of the tibia should be about here. There's really nothing that one can do at this level to restore the mechanical access of the tibia. And if one is not careful and you look at an x-ray, it's a bad ankle that looks to be arthritic, there's excellent motion in the joint, but really don't appreciate the mechanical access is off by a significant magnitude, that's not correctable through the ankle. So a slight malpositioning of the talus on the tibia can be corrected, but if the entire mechanical axis is off, that's just intuitively non-correctable at the level of the ankle, unlike the knee. This, if her principal symptom were knee arthritis, that's fully correctable through the level of the knee.
Why does that happen, that bowing?
She does have an arthritic knee, so if you think of the cartilage surfaces as several millimeters thick, as they eccentrically wear, it will cause that. In fact, that's now she has what's called a tibia vera, which is a intrinsic bowing of the tibia, so she does have a quote bow-legged, but she also has further arthritis of the knee, and it wore eccentrically. In fact, this is the most common, not with the tibia, but the most common presentation of knee arthritis is varus, so wearing on the inside and a slight flexion or bent knee contracture because of that. So that's the most common, and we do look for it, and on occasion we'll see the substantial bowing, again not correctable through a standard ankle. And historically we'll correct some of these deformities if they're at the level of the ankle. This was a surgery that I performed on a fellow that came in asking for an ankle replacement, and he had a valgus alignment, so he had a more flat foot positioning due to a non-malignant tumor of his fibula. So this is bulbous deformity, is a non-malignant tumor that he has as a child. It's a stable mass and it's benign, but it led to a growth abnormality at the level of the ankle. And replacing an ankle in that malaligned position is not technically feasible. The recommendation is to restore the normal mechanics of the tibia, and then once that's healed, consider alternative treatments for the ankle arthritis. This was before what's called a supramalleolar osteotomy. So we cut the tibia, realigned it, anticipating, and I put this as part of an ankle replacement talk because that was the discussion, is this is going to be stage 1. And then stage 2 is, okay, your mechanical access is better aligned. Now we can replace your ankle. And this was the side version of the ankle after the osteotomy. And interestingly, he's never had an ankle replacement because once we realigned his ankle stopped hurting. And that does come up quite a bit. So the results are difficult to interpret, sadly. There's multiple implants, multiple surgeons, multiple designs. No one has an idea of what is an acceptable outcome. Is an acceptable outcome that you didn't have another surgery? Is an acceptable outcome that you didn't have your leg amputated? And that's not being facetious, that is one of the outcome measures. Or is the outcome that your pain is reduced? Is the outcome that your motion is maintained? So when we talk about what is the outcome of a total ankle arthroplasty, recognize that the outcome is typically a catastrophic failure, a second surgery, and then some x-ray parameters on survivability of the implant. Did it subside? Did it shift? Did it move? Did it fail blatantly or crack? There are multiple studies, multiple meta-analyses where multiple studies are pooled together to analyze, and then there are individual implant studies, most of which show a tail off of the implant survivability, and it happens typically at about 10 years. Interestingly enough, the correlation between pain control and the implant is not always there. There's this sarcastic term we have in orthopedics called a successful failure, where we get an x-ray, the surgeon is displeased with the appearance of the x-ray, but the person is doing quite well. And we do have lots of those folks out there where a bone shifted, a pin moved, but there's no reason based on symptom that we would intervene in that circumstance. So survivability of the implants are influenced by that notion of successful failure. There's a lot of folks who are followed with their orthopedic devices and never had one of those markers of failure interventions. The STAR Arthroplasty, the one that has been implanted at Concord Hospital, that has a 10-year survivability now that's published, upwards of 90%, and so it's considered an acceptable risk in the world of total arthroplasty to proceed. Multiple implants also. And then the final question remains, what's the difference? We have a gold standard procedure that we know, and then a emerging procedure that we don't. And the head-to-head comparisons are very difficult because the exclusion criteria eliminates a good head-to-head comparison. How do you compare the apple to orange? This person isn't a candidate for this procedure, so how can you compare how they would have done if they had the procedure? So multiple studies, but logically there's no comparison. It's very difficult to compare the two. The complications are known. These are not new, and this is true for all arthroplasties. Delayed wound healing, deep infection, and then, quote, subsidence of the implant. This is an example of a buccal pappus and then a star that wasn't mine that I had to borrow that x-ray, highlighted where this piece of metal is in the plastic itself and it's eccentric, so this implant has subsided. And then other complications that we'll see is what happens when the implant fails. This is an example of what happens when an implant is taken out. We have a large defect that has to be filled with something. This is a tibio-talar calcaneal arthrodesis rod. It's a very extensive procedure to fill in the defect. And the final slides, this was a sarcastic slide. Who is qualified to put in ankle replacements? And we'd like to think that you really need to be the highest level of training, but interestingly enough, the groups that were compared, surgeons who are foot and ankle specialists who took a course, surgeons that went through a fellowship training program, and then observed, observational was the second. They all had around the initial same complication rate. So I would like to say that it's important to be as well trained as possible. And I think it's intuitive regardless of this study. So I'm going to go ahead and stick with I think it's important to be well trained in this. But in light of full disclosure, this has been studied. All right. And then they did look at surgical complication rate, and I think this is where the difference is. When the hospital approved to be doing these devices, the first question was asked, well, how many of these have you done? And the answer in Concord Hospital is none. But going through training again with the different implants, same technique, too numerous to count on 30 or 40 of the other arthroplasties. And that was really what matters in terms of complication rates. And then the emerging thought is that hospitals that do lots of arthroplasty have that process that's very refined, and we do see less complications with that. The growing trend is that even though it's economically disadvantageous to the smaller rural hospitals not to offer some of the larger procedures, realistically the thought is that it should be done at larger centers where more general surgeries are performed, more arthroplasty procedures are performed. This last slide, or what happens when patients fail. We'll fuse the ankle. These are very complex procedures to reconstruct the ankle. This last case, interestingly enough, this was the first arthroplasty that was implanted in the state of New Hampshire. This was not done in Concord Hospital. This is a agility arthroplasty. As part of that procedure, these two screws, which are intentionally placed as part of this technique for this implant, is to try and get this area to meld together and fuse. This is what's considered a catastrophic failure due to, quote, subsidence. So again, if you remember that first slide where the talus bone had that contouring with the metal cap, there is no contouring. The entire implant has subsided deep, well below the level of the talus. So this was grossly moving and basically smushed or subsided, and the entire length of the leg had been diminished. This was removed. These are very large surgeries. At the time, there was no good revision implant. That's not true these days. At least that's a possibility. This was a cadaveric graft. This is a large bulk allograft that's used to take to supplant the volume loss due to the subsidence. And then I selected an implant that goes through the entirety of the tibia. This is a similar tibio-talar calcaneal arthrodesis rod that goes through the marrow of the tibia and holds the positioning. I removed one of the screws, and then over the years the bone has fully mended. And even though the technology does exist to now take this apart and redo an arthroplasty, she has chosen not to do that. She's okay with the fusion. Revision. There are implants these days. This is an emergent science. Most of these are customized implants for failed ankle arthroplasty. We can 3D model now. There are companies that will 3D model the individual leg, and we can do individualized implants. But this is an emerging science. There's 500,000, could be wrong in this, more knee replacements done in the U.S. per year. We're looking at probably less than 10 or 15,000 ankle replacements. So statistically, seeing if you have a large volume, you can recognize small problems. So with 500,000, you can see a 0.01% problem. It's going to take years to see that 0.01% problem if you're doing 10,000 a year across the country. This was the most recent, larger presentation, and the results again correlate with ankle arthroplasty is ultimately here to stay. The results are emerging. This was not the latest, rather. This was the first large study that really solidified the presence of ankle arthroplasty. So just to conclude, thank you very much for being patient with me. I think the data is getting there. The more arthroplasties that are done, the more refined the techniques, the better the indications and the better the results will be. I would caution, this is technically a very difficult procedure, and the complication rates can be high if not very selective. And the reason that we are doing this now at Concord Hospital, even though I did this 15 years ago and stopped, is because the designs are getting better. The implants are better. The technique is the same. The anatomy hasn't changed in the ankle in those years, but the design and the refined techniques have. And most importantly, the patient satisfaction is high. This is an implant and a procedure that can help restore function. And I think that's ultimately one of our goals in orthopedics. I put in the marketing slide. Interestingly enough, this has been looked at in numerous ways. Patients get what patients want. I've had lots of folks who I felt that were not ideal for an ankle replacement, and they went elsewhere. And I will stick with my opinion regarding some of those things. And if those folks decide they're going to go elsewhere and have a questionable questionable judgment used, then that's the way it is. But it really does speak towards a lot of the studies of ultimately people get what they want. And that was it.
So I have a question. You had a slide that said the ideal candidate was active, but
Yes.
not an athlete.
Yeah.
So can you expand on that more? What if somebody goes to the gym regularly? Is that,
So
does
those
that
are my
disqualify?
Sure, that's all right. Those are my thoughts, not anything written in stone. There's almost no other implant, and this is probably true with hip and knee. It's been 20 years for me for those devices, but these are mechanical parts. And if you think of how many cycles a mechanical part has to its life, if you use those cycles cautiously, then the mechanical device is going to last longer. And with just stepping 5 to 7 times body weight, with an impact, it can be 10 to 15 times body weight of force across that interface. It's just not going to last that long. So even the most successful of implant with those mechanics, doing high-end cutting, high-end impact, it might be okay, but it's ill-advised.
Thank you.
How did you get into ankles?
As a specialty?
As a specialty.
I'll give you the Cliff Notes version. I wanted to do trauma. I had a strong interest in trauma. I trained in a program that was very heavy in trauma, and it was something that was very important to me. But it was a family decision that I probably would be ill-suited because I was never around. This field allowed me to pursue that. It's foot and ankle trauma is, everyone has their own biases, but the disability is the highest in foot and ankle trauma. The complication rate is the highest. It's the most challenging to get right. Someone breaks their neck, their back, their pelvis, their femur, and their foot and ankle in a car accident, heaven forbid. It's the foot and ankle that leads to the highest disability, period, in all studies. So it was always an attraction to me based on the technical challenges. And this field also allowed me to pursue another part of myself, which is wound care. I sadly got into that through the military, and I'd like to think that I do a good job with it, and it's something that I've been able to pursue because of this field.
Dr. Gentchos, one of the contraindications was 55 years old, question mark.
Yeah.
I was intrigued by that, number one. And then the second part of that question, what's the recovery plan for this? I think we're pretty good now at understanding what hips and knees are.
Right.
What is it for this?
So the 55 is just, to be honest, random. When I first was training, it used to be 65. The idea is, again, how many cycles do you have before this implant's going to fail? And as the techniques have refined, interestingly enough, there are surgeons or orthopedic foot and ankle specialists who feel that even if an implant fails, so if you're putting an implant in a younger person and the implant fails, with the improved techniques of revision, it's actually easier to take care of a failed implant than if you were to fuse an ankle in that 55-year-old and now the joints next to that fusion are degraded. That doesn't have very many attractive options. What we can do in that circumstance when someone is now 10 or 20 years into an ankle fusion and they have a substantial degree of discomfort, the options are poor. And all of them reduce function even further. But a failed implant potentially has more options. So that number was arbitrary. It continues to be arbitrary. But I think if you pooled and asked for a raise of hands, you'd still see some sort of number like that. In terms of the recovery, again, opinion. So the protocol that I would say most people follow is about a 3-week for the initial 6 weeks. So 3 weeks of some sort of weight-bearing restriction. These usually sutures. Most people don't staple the skin. These are sutures in the front of the ankle. They'll typically come out at 2 to 3 weeks. And then after the 3 weeks, then we allow weight-bearing in a walking boot. My experience in the past and currently is that folks will stay in that walking boot a lot longer than expected because the ankle seems to stay swollen for a very long time. So usually say somewhere of the first 6 weeks is relatively set in stone. The second 6 weeks it's weight-bearing, removing the boot for ankle mobility exercises. And at 3 months, we try and move past the walking boot, plus or minus physical therapy, periodic radiographs for surveillance and maintenance to ensure maintenance positioning. But my past experience and my current experience is that even at the 3-month mark, we're still seeing folks going at least back and forth to a boot.
Thank you.
We
Did you have a
don't
question,
have
Tia?
we don't have any questions on Facebook right now.
Okay. Well, thank you very much for the opportunity.
Thank you.
It's certainly unique unique and different to give a presentation with a surgical mask on, but as we're all aware, even in a large open room with, as you were probably aware, $1 million air filtration system,